But really, the question is, what happens to a woman when they're told they have breast cancer? And what do they hear? And it's sort of like me being at home talking to my kids once I ask them to do something. Once a woman hears the words breast cancer, they hear nothing else because it's a tidal wave of emotion and fear coming over them. And when I say they hear nothing else, they just see my lips move. And again, it's like my kids. They don't hear a word that I'm saying. And it's fascinating when you ask them what they heard from that initial conversation. The only thoughts that went through their minds are, I'm going to die. Am I going to die? I'm going to die. And they're having this debate in their head. And if they have kids, especially young kids, all they are thinking is, I won't see them graduate. I won't see them grow up. I won't see them get married. I won't be there for them. And then they're thinking, holy crap, my husband has to raise these kids. What the hell will happen to them? They will be in jail. My husband will be visiting them in jail with his new wife that's 20 years younger than him. So these are the thoughts that are going through their minds. And somehow it's my job, and it's a tough job, because it's a tidal wave of a job, to bring them back to reality, that they're not going to die from this. And they will see their kids graduate. And they will see their kids grow up. And their kids hopefully won't be in jail. I can't guarantee that their husband won't be with someone 20 years younger than them. That still might happen, but it's not because of breast cancer. It's because it might still just happen. How do I know this? And it's because, number one, I do this every day. And number two, this is a personal journey for me. And every woman I take care of, I have skin in the game. Because when I was in med school in 1992, I got a phone call from one of my first cousins, who was like my older sister. And she said, I found a lung. I was like, what do you mean you found a lung? She said, I was putting my bathing suit on, and I found a lung. I was like, okay, what'd you do about it? She said, I called you. I was like, I'm a med student. I don't know anything. You have to go to the doctor. So she went to the doctor. She had a mammogram, all this, and she has breast cancer. And she's 36 years old. And she has a 5-year-old and a 3-year-old. And she said, I'm going to die. I'm not going to see them grow up. I'm not going to see them graduate. I'm not going to see them walk down the aisle. And I said, I don't know enough about breast cancer. I hope that's not true. I just don't know enough about breast cancer, though. But I'm going to learn everything I can about it. And she had a lumpectomy. She had a dreadful cosmetic outcome. And she had to go through chemotherapy. And this is how far we've come. She was on a clinical trial in 1993 for a drug that we've gotten away from using because we have so much better now. That wasn't that long ago when she was on the clinical trial. Unfortunately, she didn't make it. And I promised her that I would spend the rest of my career making sure that that didn't happen to others. And that's why I do what I do. So every patient is a personal journey. Unfortunately, since then, I've had 10 other family members diagnosed with breast cancer. So when I say this is personal, it's personal. Why do I have the conversations that I do with my patients and spend so long with them? Because before I did this, I went to a few of the appointments with family members. And they left knowing as little as they walked in the door knowing. I was like, well, What about this? What about that? Oh yeah, that's a possibility. Oh, chemo's a possibility? Did you think of discussing it? I'm the surgeon. I don't talk about that. Oh, we don't talk about surgical incisions? Why not? These patients just want to live. They don't care what their breasts look like. I don't know. I think they do. I think they really care. Thankfully, every other family member has survived, half of which I started operating on and taking care of because the other breast surgeons didn't care enough. My job is not only to take care of the patients to the best of my ability, and again, it's a personal ability, and I can guarantee you that every patient knows that and feels it. But to educate other doctors and to educate patients that that's what they deserve. They deserve to be taken care of. I train fellows and residents, and I've trained over 25 fellows since we've had a fellowship. And it's really easy to take care of breast cancer patients and all patients. Treat them like you want to be treated. Talk to them like you want your mom, your grandmother, your sister, your cousin, your kids spoken to and taken care of. Spend the extra time. It's really easy when you think about it that way. So do we have skin in the game? Yeah, we have skin in the game. This could be us. This could be any of us in the room. It could be any of your parents, any of your spouses, any of your children. That's how you want the doctors thinking about this. It's not one size fits all. It never should be. It's personalized medicine. All the technology that you have is great, but every patient doesn't need it. It's really personalized. Some people need it, and some people don't. It's personalized. You guys need to get out there and have skin in the game, because if it's any one of you, you want personalized care. That's what this is about. That's what we're doing. This is a tidal wave of change for the way that patients are treated. Patients deserve the best treatment that they can get. That changes every year. Look at the slides that were up here. This started with a concept, and look where you've become. Look what you as a company have become. I'm sure most of you have worked at other companies. And every time you get out there, you are changing the way breast cancer is treated. That's what you're doing. You are the force behind this. The doctors, after a while, will listen. The question comes up to me, when you guys, why are doctors resistant? Change is hard. Again, tidal wave. Nobody wants to be hit with a tidal wave. So when you think about it, in the 1970s, every woman with breast cancer, and granted, the breast cancers that were diagnosed in the 70s were larger because mammographic screening wasn't around. So they waited to feel the breast cancer. So 2 centimeter, 3 centimeter breast cancers were common. Every woman had a mastectomy. Even with triple G breasts, yes, they do exist. 2 centimeter cancer, that's like a pea in her breast. But she had a mastectomy. And all of a sudden, women started saying, hang on a second, why am I losing my whole breast? Oh, and by the way, there was no reconstruction. So for a pea-sized breast cancer, she had a mastectomy. And women came out and said, hang on, I don't want this. Why do I need to lose my breast? Well, that's what we do. Well, why don't we do something different? That's not what we do. Surgeons, they're really hard to change. Pretty pig-headed. Why? Well, in my residency, we worked on average 140 hours a week. Last time I checked, there were only about 156 hours in a week. We have to be pretty pig-headed to sign up for that. So surgeons are pretty pig-headed, and they don't like change. So they have to sort of be beaten over the head with it. And it comes from patients. So the original study that was done, because you have to make sure it's safe, was comparing a mastectomy to a lumpectomy, and then a lumpectomy plus radiation, a 3-arm trial. And they were looking at overall survival and recurrence. The lumpectomy alone arm dropped out pretty quickly because of the recurrence rate. And then we were left with the lumpectomy and radiation compared to a mastectomy. And guess what? Overall survival was equivalent. So again, we asked, well, why are we doing mastectomies for everyone? And this was slow to change. You went to doctor, no, mastectomy is still the safest thing. No, we have data showing it's not. But that was all they knew how to do. So they started adopting lumpectomies without a care to how it looked. Because that was cosmetic. That doesn't matter. The woman's alive, that's all she cares about. Well, that's not really all she cares about. But in 1970, women weren't really allowed to say anything different. I just read, and I don't believe everything I read, but it was from a few sources, that it was not until 1974 that a woman could get a credit card in her name with her own credit rating. So in 1970, women certainly were not allowed to talk about the appearance of their breast. In fact, it wasn't until Betty Ford came out and said that I have breast cancer in public. It was the first time it was discussed in public in the media. Betty Ford was a pretty special lady, very brave. Before that, it was a woman's cancer. It wasn't discussed because a woman had a mastectomy without reconstruction, and no one except her husband would ever know. Well, that's a pretty crummy way to live. There were no gyms that women went to in the 70s, so no one saw their breast, and they hid it in shame. Breast cancer was a shameful thing. Now, for God's sake, Angelina Jolie's on TV talking about her nipples. Well, I mean, we've come a long way. Sometimes it's TMI, but it's a long way we've come. And think about that. Again, it's patients pushing this. We have to get patients to know, and women to know, it's okay to care about your breast appearance. This is not cosmetic. We have to get rid of the term cosmetic when we talk about breast cancer. With all due respect, if a man has penile cancer and has his penis removed, it is not cosmetic to replace that. When a man has testicular cancer and has an orchiectomy, it is not cosmetic to put in a fake ball. For God's sake, what do you need that for? But yet, it's never questioned whether insurance will pay for that. Of course they will. A man needs that ball. Please don't record that as a gem.
Yeah, I got it. I got it.
Not the gem. So this is not cosmetic. This is all tied to body image. And every study out there will tell you that body image is important. And when looking up the definition and really what body image means to a woman, there were multiple definitions and multiple meanings. Sense of appearance, sense of wholeness, sexuality, functionality, all these things. I mean, in New York City right now, when you have a baby, if you don't want to breastfeed and you want to give the baby formula, you have to get special permission because the breast serves a function. Then why is it cosmetic to replace that breast? It's not. So I urge you to stop using the word cosmetic outcome. It is not cosmetic outcome. That demeans and minimizes what we do. And I talk to every patient about that. When they say, oh, I don't want extra surgery for reconstruction, I don't care how I look. That's today. Because all you're thinking of is, I want this cancer out. But I know, statistically, you will go through breast cancer treatment and statistically never have another problem from breast cancer again. So I know, as their doctor, I don't care about breast cancer right now and what they look like right now. They want to live. They want to see their kids graduate. They want to see their kids grow up. They certainly don't want to leave their kids with their husband and a woman 20 years younger. They want to be there. So they're not thinking about their body image. I know that they will be thinking about their body image in 3 years, 5 years, 10 years, 20 years down the road. Because chances are they will die with a history of breast cancer, not from breast cancer. So it's super important because it affects every part of their life, what they look like. I don't know a bathroom without a mirror. There are women who I see who've had breast cancer years ago, treated by a different surgeon, thankfully, who come in and say, when I take a shower, I turn my back to the mirror when I get out. I don't want that for them. I want more for my patients. I want more for every woman with breast cancer. They deserve better. And that's what this technology helps us deliver to them. They deserve to be proud of what their breast and body looks like. Why do I do this? Because every day I have a woman come in and she says, I got my mammogram and they couldn't find the scar. And they say, who was your surgeon? I want to go to her. That's what I want for my patients. I want them to feel that good about their breast. I want them to say, wow, I'm so happy when I look at my body. And the reason is, if a woman looks at her breast and there's this big divot in it, or this big scar standing out, breast cancer is never far from her mind. 5 years down the road, 10 years down the road, 15 years down the road. Every day she showers, she sees that. So every day she thinks about breast cancer. If she can't see that scar, guess what? Every day breast cancer gets a little further back in her mind to where she only thinks about it before she comes in and sees me. It's kind of like going to the dentist. That's awful. But that's when she thinks about it, before she gets her mammogram, once a year. What's better than that? I mean, that's what women deserve. That's what we want for our patients. That's why I do what I do. That's why you guys do what you do. Women deserve this, and they want it. And then that woman goes out and says, hang on a second, why do you have a big scar? Because, they all show each other their breasts. It's amazing. At dinner parties, they're like, do you want to see my breasts? Not really. I really don't. Well, it looks pretty good. No, I really still don't want to see it. So, I have enough on my phone. As my kids scroll through my phone to show their friends pictures, they're like, oh, Mom, really? But one of the best stories is the kids in one of my daughters, I think she was in first or second grade at the time, and they're learning about Google searches at school. And my kids go to a Catholic school. I just want to torture them more. So they're learning about Google searches, and they all have smart boards, so it's a big screen. And somebody says, well, let's look up, the teacher says, let's look up someone's parent. Whose parent is going to be on Google? And of course my daughter's like, oh, my mom's famous, she'll be on Google. She's like, okay, and she says, well, show us how you do the search. So she pulls it up, and she pulls up images, and there's this picture of a breast with a nipple, and it's up on the smart board. She's like, Mom, I was so embarrassed. The teacher couldn't figure out how to get it off. She didn't know how. She was all, she's running around the classroom trying to get the picture, and the boys are going, wow, that's her mom's breast. So she's again. It was so awful. And I was like, well, I thought that was pretty lit. I torture my kids. I like to use their terminology just to torture them. But that's what this is about, torturing our kids. Now, this is really about, we're advocates for women. Why doesn't every breast surgeon do this? First of all, one of the problems is that the overwhelming majority of breast surgery is done by surgeons who do fewer than 2 breast cancers a year. Well, they're not going to learn this. They're not going to learn something new. Those are also the same doctors that did mastectomies on every patient. And compared to a mastectomy without reconstruction, the worst looking lumpectomy is still better than that. So now, you have to change their focus. And to them, this is purely a cosmetic procedure. A woman should be happy she's alive. Well, I think that we deserve a little better than that. Again, we just have to change the culture, the way physicians think. And more importantly, because to be honest, there's more women with breast cancer out there than there are doctors taking care of them. So who do you want to target? The doctors or the patients? I'd be targeting the patients. I'd be teaching women that we deserve better. We deserve to have our breasts looking great. When I'm thinking about where I'm putting an incision for breast cancer with a lumpectomy, there's only 3 choices in my mind. I'm a pretty simple person. 3 choices. Oh, they all happen to be hidden. Axillary, inframammary, and perioreolar. And we can't accomplish that 100% of the time, but we're pretty close. That's what our goal is. That's what I teach my residents, that's what I teach my fellows. And they go, well, nobody else does that. Well, that doesn't mean that it's right. Just because we can do something like a poor outcome doesn't mean we should. Is it easier? Yeah, it's way easier. Make an incision right over that cancer, that makes life much easier. In fact, it takes me half the time. But that's a short-term look at this long-term issue. Short-term is do the easiest thing, take the shortcut. That's easy for us. Long-term view is this woman's going to be living with her breast another 40 years, looking at it every single day. We want better for them. When they walk in my office and I do a breast exam, I want to be proud of what I did. Really proud. I want to look for the scar. There are times where I go back to my chart and where was that scar? Because I can't find it. And I was like, wow, that looks great. You have no idea how many times a day I tell a woman her breasts look great. It's really embarrassing after a while. And I listened to myself and I was like, ooh, I don't know if I should be. I was like, your breasts are fantastic looking. I was like, ooh, I don't know if that sounded right out of context. But it really makes a difference. You guys make a difference. You are the tidal wave of change for breast cancer in 2017. You have to believe that. You have to get out and talk to doctors about that. This technology is not necessary for 100% of patients. One size does not fit all. So when I talk to doctors about it, or hospital administration about it, or value proposition committees about that, as I did, they're like, well, you're going to use it on everyone. No, I'm not. Realize we do have some responsibility in this. I'm going to use it on the appropriate patients. If I'm doing a nipple-sparing mastectomy, I need this. If I'm doing the old-fashioned mastectomy without reconstruction, I don't need this. So I'm not going to use it on everyone. But if I want to do a lumpectomy with a scar that's hidden and give this woman the best chance of forgetting about breast cancer, then I need this. And it makes my surgery better. And it gives that woman infinitesimal better quality of life. It's amazing the difference. Talk to women. Talk to women who and how they feel about the way their breasts look. It's amazing. We did a study in my hospital years ago, before Ingenuity existed, and it was about body image. We found that women who were not satisfied with the appearance of their breasts, it affected every part of their life. They were divorced more often. They exercised less often. They changed jobs more often. They had sex less frequent. God knows we don't want that. It affected every part of their life. That's how important body image is. That's why this is not cosmetic. It is not cosmetic. And I tell women every day when they go, oh, I don't care about how it looks. Don't minimize that. Don't demean what body image means. It's super, super important.